the extent of the lesion and whether there are single or multiple tumors. We are very particular about documentation and drawing and measuring, and we often do this and encourage our residents to do the same because sometimes the patient gets lost to follow up and they come back and the tumor has increased and there are small features which can be picked up, including we also do photographs. Lymph node examination is important, especially the pre-auricular, submandibular and the anterior cervical nodes. Lacrimal drainage involvement is also done for especially diffuse lesions or lesions involving close to the upper or the lower puncta. Radiological diagnosis can be done and augmented by the USG, CT scan and MRI. So what are the red flags in eyelid lesions that should actually be marked off? These are some of the ones that I consider a checklist or encourage our residents to consider any eyelid lesion and evaluate it on the basis of this. So coming to size, you can have something which is growing slowly, something which has grown slowly with certain changes, or something which has grown rapidly over a few days and months. Obviously, rapid growth indicates is more towards either a catastrophic event or possibly a malignant lesion. We have ulceration, bleeding, crusting, margin notching. Most often this indicates that the lesion is trying to either break out or causing destruction or necrosis, as is seen here, and it can even cause lid notching. We have something called as telangiectasias or feeder vessels, as is seen in the small but very significant dilated vessels seen on the upper eyelid, which had growth significantly over the last couple of weeks. Sometimes you will also see marginal lesions which have intrinsic vasculature. Some of these lesions can mostly be benign, but very large dilated vessels often point to malignancy. We have loss of flashes, especially for marginal lesions, which means that there is destruction of the tissue or possibly invasion and indicates malignancy. You have nodularity, which needs every eyelid should be everted. You have to see the meibomian glands to see the thickness of the lid margin and the effacement of the meibomian glands, and other structures other features such as altered pigmentation, associated infection, inflammation, and the history of repeated surgeries. Eyelid tumors are classified into primary, secondary, or metastatic, and primary are further classified into benign or malignant based on the tissue or the cell of the origin. We also have masquerades in the form of inflammatory and infectious lesions which often mimic certain eyelid tumors. So this is a scenario which you often see in your OPD. So let's take it step by step. These are small multiple lesions which can be sessile or pedunculated with finger-like projections seen in the upper or lower eyelid scattered in various places. They often have small intrinsic vessels and is seen here, and can also be pigmented. So here it's a slow-growing multiple lesions with little bit of intrinsic vasculature and none of the other red flags, commonly known as papilloma, which can either be observed or excised. Now this appeared to this gentleman as a very slow-growing lesion, but over the last couple of weeks, he developed ulceration over the lesion with recurrent bleeding, and that raised a red flag. They also has a very specific small whitish lesion with a small crater. These are known as keratoacanthomas and can be nicely excised and are variants of squamous cell carcinomas and known as premalignant lesions. When there are multiple such lesions, you should obviously ask for a history because it means that they may have another syndrome called as internal Muir-Torre syndrome. Similarly, if you see a structure like this, which looks like the previous one, but has a slow growth with sudden ulceration, there is some intrinsic vasculature, possibly a presence of keratin as is seen here, but is elevated nodular plaque-like and pearly irregular margins as is seen here, rolled in as a grayish-white appearance. It's most often either a squamous cell carcinoma. Similarly, this tissue shows an exuberant keratin. Keratin is almost a giveaway that it could be either a premalignant or a malignant lesion. Now let's do a small googly. So this fits into the size. This is multiple lesions with ulceration, loss of lashes, especially this one, which is very, very strange. But this lady had it in the upper and eyelid. But if you were to only focus on the eyelid, you'd often miss the real picture. So if you take a look at the lady, and you also see that she has multiple umbilicate lesions, these are molluscums. So though these are ulcerated, loss of lashes, and traditionally raise all the red flags, you need to also take a step back. On further history taking, it was noted that she was an uncontrolled diabetic. So this pointed more towards a secondary infection, and on a simple course of 7 to 10 days of antibiotics, this is how she resolved with regaining all her lashes and a good lid margin. So not all red flags turn out to be a malignancy, but you definitely need to be suspicious. Coming to other lesions, which are slow growing and have ulcerated, but also have some amount of pigmentation. They are firm and they have usually a tumor, they have a margin which extends beyond what is seen. They are dome-shaped. They have invading edges or poorly defined margins. These look sometimes similar to squamous cell carcinomas, but are classically basal cell carcinomas, especially the pigmentation. So squamous and basal cell carcinomas are the commonest epidermal tumors associated with actinic keratosis, xeroderma pigmentosa, as is seen in the pictures here. These lesions need to be at least tried to identify early and possibly either referred or a biopsy done to be identify and define it from a benign from a malignant lesion. Coming to the next lesion, we just evert the eyelid. So what appears as a very small thickening of an eyelid margin shows a small lesion with a little bit of a normal area and another skip lesion. Now the main thing out here is, besides all the red flags, once you evert, you can see there's a thickening of the lid margin. The meibomian glands are obliterated and his hair has a classical yellowish appearance. This is the same gentleman who got lost to follow-up for about 3 to 4 months and came back with a large sebaceous gland carcinoma. So often you see burst lesions which form a granuloma. The difference here is the color. Those appear pink, reddish, while these are classically very, very yellow. This is some of the other forms of sebaceous gland carcinoma, and the other features are tarsal thickening as is seen in a diffuse sebaceous gland carcinoma, or may appear as a very concise nodular lesion. We often see eyelid lesions which are deeper, most often seen in children classically like this in our OPD. The commonest ones are the vascular lesions. They are slow growing. They often have dilated vessels, as is seen in the one here, and even big dilated feeder vessels here. The most common ones are capillary hemangioma, AV malformations, and lymphangioma. The only time that you really need to be concerned is when the lesion suddenly increases, either which could be mostly due to an infection or a bleed. Imaging with contrast is very helpful in these vascular benign lesions. Coming to lesions with a rapid growth, both these boys had a swelling over the eyelids which rapidly increased over 2 to 3 days. Often imaging along with a biopsy helps clinch the diagnosis, and these are some of the 2 most commonest malignant lesions seen in childhood. Coming to bilateral eyelid lesions, most often this is a differential diagnosis: thyroid eye disease, angioneurotic edema, or a blepharochalasis. But there are cases where you'll often see in older age groups, you have lymphoma, where the upper eyelids, both of them are swollen, then enlargement of the lacrimal gland, and on examining the conjunctiva, you will find a pinkish salmon-like appearance. Some of the other lesions bilaterally to keep in mind are xanthelisma, which are benign, deposits of cholesterol commonly seen in the upper lid, and xanthogramuloma. So to summarize, it's important to be aware of the red flags. Better be suspicious than ignorant. A good observation, documentation, and follow-up along with an augmented imaging is absolutely necessary. And when in doubt, do take a second opinion. Thank you.